How to manage as a simple renal cyst? One, two. It depends on which age the child presents. The autosomal dominant polycystic kidney disease, ADPKD, by far the commonest. It presents in the a little bit grown up child. Now, an adolescent, an adult, it is 20 to 40 years, and CKD progression by 60, 70 or so. So, 2% of them ADPKD can present as early as infancy and your neonatal period. Next one may be the autosomal recessive polycystic kidney disease. It is severe sort of disease. Usually, child presents with many cysts, multiple cysts, maybe neonatal presentation, the early presentation, infantile presentation, juvenile presentation, one, six, 7, and 13 years and afterwards. So, and your third one maybe your the nephropathy. They have initially polyuria polydipsia, tubulopathy-like presentation. Ultimately, they are now present with CKD. So growth failure is extreme over there, and the syndromic cases, the Bardet Biddle senior loken juvenile, your Zobert orofacial, Alice Ben Crevelt, Beckwith Waddleman, renal coloma, brachio, wide variety of towns and Coleman, wide variety of syndromic disease can have cystic disease. So they have systemic syndromic features. Ultimately, this renal cyst, the disease so far I mentioned, they will have good amount of them will have liver cyst in the later life. So, how to diagnose these cases? And apart from that, multicystic dysplastic kidney, multilocular cyst, they are also there, though not that common. So they present with, apart from the ultrasonic incidental cyst, they present with hypertension, and they might present with growth failure and early CKD presentations. So investigation over here basically and a good ultrasound. And at times you need to do CT and MRI urogram. And finally, genetic study is the diagnostic of those cases, and treatment of those cases basically watchful observation. ACE inhibitor is said to be a drug chosen for the reduction of CVD progression by dint of its control of hypertension and proteinuria, RAS prevention. And finally, when child develops CKD, treatment is kidney replacement therapy. If kidney is too large, it cannot accommodate the donor kidney. In case of transplant, can need to sacrifice one kidney, which is very low GFR, less than 5% or 10% or so. And ultimately, transplant is the answer. Infection control and taking care of the other security parameters, anemia, your CKD, MBD, acidosis. They are the way to treat these cases.